Welcome to Life with Ajane. I'm Ajane. We need to chat. As you may or may not know, I am someone who is very passionate about equity, justice, and specifically right now, I've been working in maternal health equity. And there have recently been some things coming out in the media about some problems that we have. First thing I saw was a New York Times article talking about how the continuous monitoring that is unnecessary in hospitals is directly tied to the amount of cesareans that we have, which a lot of which are unnecessary cesareans. That's something that's going on and takes away some autonomy from people in their births and their birth decisions, compromises a lot of different things in terms of health and safety in birthing. The next couple of things that I saw were two stories about Black women. One was Carrie Jones. You may or may not have heard this story, but Carrie Jones was someone who was waiting to get help in the hospital in Texas, and she was in active labor, and they were holding her in the waiting room and questioning about her provider and how many children she had, and these questions that are intake questions when she's in active labor, needs to have delivery help and assistance right now, but is being held in this space as she's given labor. By the time she actually got to her delivery room, gave birth within, I think they said like 12 minutes later. So, And then we have Mercedes Wells, who was a woman, I forget what state, but this was someone who was going to the hospital and was turned away from the hospital, even though she was in active labor, because she was only dilated 3 centimeters. So they turned her away, they wheelchaired her on out to the front door to get told to go home. And after she was turned away, minutes away from the hospital in the car, was forced to give birth to her baby in her car while they were driving because the hospital didn't assist her. And so, I wanted to come on and talk to y'all about this today. And I've been sitting with the information and thinking about how I wanted to chat about this, but I know I need to because this is literally just the space that if you are on the law school side of my channel, you'll know that I am pursuing law school to work on these things. And I wanted to come and talk to y'all today about this because I wanted to point out some things that I noticed as someone with philosophy training, as a Black woman who's given birth. And I want to talk about how we can protect ourselves in our birth journeys, how we can protect our families in the maternal health space. So, first and foremost, all these stories about what's going on, I think they're rooted in some systemic issues that we have with regards to race and women, and particularly when those two things intersect, how we treat non-white women in these spaces. How we treat non-white women in the maternal health space is not limited to those women. When those things become habitual practices, when harm becomes a habitual practice in these spaces, that becomes the norm. And what happens when that becomes the norm? When that becomes the norm, then everybody starts to pay as a result of this small sector of people getting those struggles. Look at things historically, y'all. When a small population gets it and it works and it's effective, it just expands. So the first thing I really want to touch on is the fact that for those of you who are like, ooh, that's really tough for those Black and brown women. Yeah, no, that's tough for everybody. Although Black women in particular are 3 to 4 times more likely to die than white women in maternal mortality rates. Let me calm down. Black women may be 3 to 4 times more likely to die than white women in the maternal care space. But what I also have you note is the CDC tells us that 80% of maternal deaths are preventable, period. That's across race and ethnicity. So I want you to understand that this is not just a Black and brown women's problem. This is everyone's problem. 80% of maternal deaths are preventable. 80%? That's unacceptable. For every 5 women that die, 4 out of those could have been saved. That's not okay. It is totally unacceptable. It is reprehensible. And we gotta do something different. Baby, we gotta do something different. That main point I really want to stick with you is that this is not just a Black and brown women's problem. This is everyone's problem. When you see injustice happening somewhere, it's happening everywhere. So, what does this have to do with like me talking about my philosophy training? Well, one thing that I have seen on the ground personally and in talking to other mothers is that a key component about women being passed over and dying or almost dying, there's a lot of people that are close cases. And when those close cases come and tell their stories, it is often the case that the story involves them not being listened to, not being heard, being passed over and pushed aside. Now, that is a form of epistemic injustice. Epistemic injustice is a term, I think it was coined by Miranda Fricker. If it wasn't coined by Miranda Fricker is a philosopher who had this take off, okay? I'll paste a link in the description box below so you can get more information on Miranda Fricker and her work and talking about epistemic injustice. But basic breakdown is that epistemic injustice is an injustice that happens in a sense around like knowledge. And specifically, there's 2 types of epistemic injustice that I'm going to talk about, and that Miranda Fricker really like breaks down in her most popular paper on epistemic injustice. There's testimonial injustice, and then there's hermeneutic injustice. And testimonial injustice happens when someone isn't being believed as they should. The level of belief that the person listening has to the person that's speaking is lowered for whatever reason. But the injustice is that they should have a certain level of credibility and they're not getting that for some kind of, usually a prejudice. Now, in relation to what we're talking about with these cases, I'm going to specifically talk about here Carrie Jones and Mercedes Wells. With Carrie Jones and Mercedes Wells, these are 2 instances of women who are saying, help, I am in labor, I'm in active labor. And I can't necessarily speak to the full thoughts and interpretations of the people working at the hospitals and their level of belief about the women being in active labor. But I'll tell you this, the actions that we see presented in the video footage show that there was not sufficient belief to be able to hold them there and help. The actions represented that, oh, it's okay, you have more time, you're gonna be fine. You might be hollering and hooting, or you might be complaining about your baby's coming, but you'll be fine. Those are the actions that we saw. And that is a problem. And I think that regardless of their actual thoughts, that their actions were enough to deem the situations of epistemic injustice and specifically testimonial injustice. And that is because when those women were coming and saying that they're in labor and they need to have assistance for their deliveries, they were not believed enough to actually get the assistance and the help. I'll speak more on that later, but let me also talk about this hermeneutical injustice piece. A hermeneutic injustice comes from the fact that they might be hard to interpret what you're going through. It might be hard to label what it is that you're going through because of different social structures and structures of power. So let me break this down a little bit differently. I think that Fricker actually talks about postpartum depression as being a type of hermeneutic injustice before we had the term postpartum depression. So before there was a term for postpartum depression, a lot of women would be going through these seasons of depression after birth, going through sadness, not eating, struggling to connect with emotions, struggling to connect with baby, lacking a will to live, right? The telltale symptoms of postpartum depression as we know it now. But a lot of them are going through these experiences And there wasn't a way to be able to label that before we started to actually investigate that further. And part of the reason that that's a hermeneutic injustice is because a lot of the framework and concern in healthcare is usually centered around men and men's issues. And specifically, like in the maternal care space, there's just so much more that needs to be researched. So structurally, the power dynamics are built in such a way that women are not researched. Women's issues are not frameworked and talked about enough to have sufficient terms for what women are going through. And we have to fight and scrape to be able to come together as collectives to be able to name problems, name issues, and start movements to better conditions around those issues. So what am I getting at with these things? What am I trying to do? I'm trying to connect these philosophy terms to what we're seeing on the ground. Part of that is so that we can avoid further hermeneutic injustice. And I want to put the flashlight, I want to put the spotlight right on what we're seeing, and I want to name it. Name it, name it. Name it.
Name them. Name them.
Well, what you did.
If you watch Real Housewives of Beverly Hills, you know what I'm talking about. But yeah, I want to name it. I want to pinpoint part of what we're seeing so that we can come out of the space of not talking about it in the first place, but also come out of the space of just seeing it and be like, oh my gosh, it's so horrible. These people need to pay. And those individuals we might focus on and they might be doing wrong, but like really this is a structural problem. And outside of those individuals, people are going to keep doing these things. Why? That's built in the hospital policy. That's built in how people just work in these spaces. That's built in how you treat Black women in these spaces. That's built with how you treat women in these spaces. You hysterical woman, hush. Oh, you're a Black woman? You hysterical Black woman. You need to hush. We'll help you as we choose to help you. And when we say we'll help you, that's what we're saying. We're seeing epistemic injustice at work. We're seeing testimonial injustice. We're experiencing hermeneutic injustice. We need to do better. Clinical spaces need to do better. We need to do better as the public for ourselves and our families in terms of educating ourselves and arming ourselves with knowledge and resources to play as a defense to the structures that at hand that are doing us harm. I really hope, if there's nothing else that I can do with my channel, I really hope that I can help people to come to understand the distinction and the importance of distinguishing between the individuals and the structures. The individuals may be doing horrible things, and yes, there is a conversation that should take place around individuals that are doing harm. I want to be very clear with, I believe that when individuals do harm, there needs to be some kind of justice there. There needs to be a conversation there. We need to directly address those individuals. But my problem is we often get caught up in those individuals and we miss the big picture. We miss the structure. And I need y'all to catch it. I need you to catch it. I need you to understand that this is so much bigger than those nurses. Whew. Speaking of that, here's another news story that's gonna play even more into the situation. The Department of Education just took all the professional nursing degrees and said, oh, those aren't professional degrees anymore. Those are just graduate degrees. And what that does is it limits how much you're gonna be able to get in government funding to be able to pursue those degrees. What's the impact of that? Why does that matter? That matters because it's gonna make going to graduate school, going to nursing school, physician assistants, those two, it's gonna make going to school to become those things much less accessible. It's gonna get to a point where you either gonna have a lot of money to pay for it yourself, or you're gonna have to go through private funders. But guess what? I'm sure what we're not talking about, and what we need to talk about too in just terms of graduate school broadly, now that they have limited graduate plus loans as a whole, predatory lenders are gonna be out here. They're gonna be out here, they're gonna be worse, and they're gonna be harassing people around graduate study. And that itself is also correlated with race and socioeconomic status. Whew, I gotta do another video on that later. But my big picture story here is the fact that taking away funding, putting a harsher cap on that, on these medical spaces that are predominantly worked by women and by people of color, is going to further harm these spaces. Mind you, they're doing this in the middle of a nurse and doctor shortage. nurses were a lot of these states' potential solutions for the doctor shortage that we have in our country right now. That's the direction we were going in. So the fact that now you're cutting funding for people to be able to pursue those degrees is gonna further make our medical shortage worse.
Hell to the no.
Things are about to get sticky icky worse than they already are, and things are already bad. Things are terrible right now, and they're about to get worse. So we need to arm ourselves with knowledge to be able to combat what's happening, and so we can be able to identify it, say, oh no, I know what that is. We need to be able to speak on it. We need to be able to identify it, and we need to do something about it. Now, here's where I get into the next part of what I need to talk about with you all. What are we supposed to do? There's a lot of things we need to do as individual people who have birthing people in our lives, or we are the birthing people ourselves. You can take some of your power back here. Few things you can do. One thing, specifically it's Black women, but just women in general, honestly. One thing you can do is I want you to look at the availability of doulas and midwives. Have a doula to help advocate on your behalf and to help with the birthing and labor process, and have someone that you've built a long, concrete relationship with there for your birthing journey. And maybe your birth doula is also a postpartum doula. There's doulas for all kinds of different things. Death, right? A doula is the person that's holding your hand and supporting you and your voice through different phases of your life. And so find you birth doula, maybe a birth and postpartum doula. Find you a midwife. There's different types of midwives. There's a lay midwife, there's a certified practicing midwife, there's a nurse midwife. A lay midwife is someone who practices midwifery tradition, but has not gone through any formal certification program. I can't say hasn't done any schooling around it, but just has not had any formal certification. There's a whole schooling system and exam that you have to take that's costly to become a certified practicing midwife. So lay midwives are the people that have not gone through that whole process. And then there's a certified practicing midwife. A certified practicing midwife is someone who has gone through the particular schooling and training and taken the certification exam and passed that and practicing with those credentials, and they have to be able to keep that credential up over the course of years through continued education and things like that. A nurse midwife is someone who actually went to school to become a nurse, got their degree, passed their nursing exam to become a registered nurse, and then went to graduate school to then become a nurse midwife. So they took extra schooling on to become a nurse midwife. So those are the different types of midwives. I will not tell you which one to do necessarily, but I will say from my own experience, I've had the experience of working with certified practicing midwives and nurse midwives, and I would recommend that. I personally felt better about knowing that someone had certification, went through a certain type of medical training, and is practicing with those credentials and are held accountable to those credentials. I felt good about that. My first birth, I actually went to an accredited birth center, and that's even more of those levels of certification that not every birth center has. So I felt really comfortable in my first birth with an accredited birth center and having certified practicing midwives and nurse midwives on staff that I saw in rotation. And when it came down to like my actual birth, that team, whoever was available at the time, I had seen everybody at that point, came and helped me deliver. And when I had my delivery, I had 3 midwives show up. So I felt just like very cared for. Now the second time I gave birth, the birth center I went to was not accredited, but it was the only birth center in the area that I lived. My first birth, there were actually a few birth centers to choose from, a few different kinds of midwives, doulas, and galore. The second place, we moved to a different state and much less access, much less options. There was only one birth center that was available to me. There were 2 birth centers that would give birth to people who wanted to have home births or birth center births in the area, but one of them had just built an office in a different city and wasn't taking home births at that point. And I was sad because that was the one that came more highly recommended. But I went with the other one that was available, which was a birth center here. in the exact same city and was taking on clients, and I generally had a good experience there. With both birth experiences with my midwives, I felt listened to generally. The appointments were much slower. Things were explained much more clearly. Why am I saying more and more and more if I only did midwives? Well, I didn't. The second time that I gave birth in the place with a lot less resources and availability and options, I actually chose to do OBGYN appointments and work with them as well. I wanted to have that direct experience to be able to compare and understand more of what's happening in those spaces. And what I experienced was a lot. With the OBGYNs, the appointments were fast. And also it took me forever to even be seen. On top of that, when I said that I was going to have a home birth, I was actually turned away and was told that I didn't need to be seen by an OBGYN, that I didn't need those services. And I was turned away and told and hung up on as I was trying to get an appointment to be seen and to start getting the situation set up to be seen by an OBGYN. There was a whole like structural process where you had to be phone interviewed first, and those appointments took forever to get. And then after you had to get a confirmation appointment. Yeah, you had to go and actually get the birth like confirmed in person with blood and or urine, which I did. Then after that, you had to get a phone appointment to be talked to by a nurse. Then you would be eligible to be seen by an OBGYN. But you had to get that phone call first, and the wait to get that phone call was ridiculous. So the earlier you start that process, the better. But when I tried and I said that I was having a home birth, but I wanted to be seen by an OBGYN, boy, they turned me away. They hung up on me. Because there's bias against people who do home births in the clinical spaces. And the clinical and traditional, I'm calling traditional referring to midwives here, they don't talk a lot. I'll say a lot. Some people talk and some people work, but they're overwhelmingly, those spaces are not crossing. So that was traumatic. And then my insurance actually was the entity that made me go back, because they were like, oh, we need your birth confirmed, but it can't be confirmed by just the midwife, even though the midwife is a certified practicing midwife, had a whole birth center. And my midwifery birth was covered by my insurance, but they could not confirm the pregnancy. The pregnancy had to be confirmed by a medical doctor. So then I went back, but at this point it's months later, my pregnancy, and the crazy part was that I tried to go ahead and say, okay, it's already been confirmed, I need to set up my phone appointment. The nearest phone appointment they told me was in July. I was due in August. That's for the phone appointment, mind you. Again, you have to see the phone appointment before you see OBGYN. And so they weren't trying to have me see anyone until weeks before my birth. And I wanted to see someone throughout so that if an emergency happened and I had to go into the ER, those people would know me, know my face, and would have some kind of bond. I wanted to feel secure that they would actually take care of me. I wanted to know what it was like interacting with those people that would be responsible for me if my life and my baby's life were on the line. Woo! And they were making that difficult. But through some tenacity, I went and I called all the offices that I could to try and see if someone could see me sooner. I was willing to drive across the state to go and get seen sooner, but my insurance didn't cover outside of my part of the state. So I couldn't even do that. There were appointments available in other parts of the state that same day that I was calling, but I couldn't go to those appointments because my insurance, they wouldn't take my insurance out there. My insurance wouldn't cover coverage outside of my area of the state. It was by the grace of God and the ancestors, okay, that I actually found someone here in this area that said, oh, I can see you within like the next few days, or I think within a week. And we had our phone call, and that got me to be available to see someone. And instead of waiting until July, I think I was starting to be seen in like January, February. It was like top of the year. And so I had a few months to go and do my OBGYN appointments in addition to my midwife appointments and compare and contrast. Now I'll say my direct experiences with OBGYNs were generally positive. Felt like I was being listened to. I was being kind of coaxed, or they were attempting to convince me to give hospital birth instead of home birth because they were scared for me. And they were saying that the cases that they see of people who come into the hospital from dealing with midwives were really like severe cases and they should have got there sooner. And so I was like, okay, but like, so tell me what to tell my midwife to get here sooner. What should I be on the lookout for? What should I tell my family so that I make sure we get me the ambulance called sooner? So I'm not one of those cases where you see in this late. Tell me that. Tell me the information. And so, yeah, I stuck my heels in the ground on I'm doing my home birth. I want to give home birth. I do not want to be in a hospital because the hospital does not listen. They're killing Black women. I don't want to die. And that's not your direct fault, but structurally, things are set up to where I'm not going to be listened to and I don't want to be here. I want to be at home. After I give birth, I can go to my bed and I can stay at home. That's what I want to do. So, anyway, OBGYNs generally, we're fine. And we had some good conversation. The people that I struggled with were actually the people before I would get to the OBGYN. The first person that hung up on me was not an OBGYN. That was actually somebody that was doing intake calls. Another person I had a negative experience with was someone who I was talking to, or like I refused to get a drug test. Yes, I did. The drug test is optional, at least in my state. And Black women were very much so disproportionately drug tested compared to white women. Every Black woman was drug tested compared to like about 70% of white women. So in protest, I said, no, you're not drug testing me. We're gonna get that down to less than 100%. You're not gonna drug test me. There's no reason to be drug testing me. I have no history of drugs in my chart, my file. I don't do drugs. No, I'm not gonna do it. I'm not a criminal. You're not gonna make me. I'm not doing it. Because I refused that though, I was treated differently. Needle was snatched out of my arm by the person who was drawing my blood. I was also given a lot of looks and glare. Like that whole blood draw appointment was very uncomfortable. Here's my point. You can take some of your power back. You can see midwives. If you have the option, if you're not a high-risk pregnancy, an option you may have, depends on availability where you're at. Like I told you, that second time around, it was a struggle. But I say it's worth looking at options of going to the midwives. Now here's the thing about that. Insurance may or may not cover the midwifery. That's a struggle across the board where sometimes it can be difficult to get insurance to cover, or it's a fight. Listen, to get my insurance to cover it the second time was a fight. So you may have an out-of-pocket cost. But sometimes with those things, they'll work with you on the cost, or they have like a sliding scale, or maybe they'll have something where you have payment plans and installments. And you just have to pay by a certain amount by this certain week of the due date. So I'll tell you this, if you're planning right now for your pregnancy and you're interested in the midwife option, I will say look at your options for midwives in your area. Check the price, get an estimate on the price. Save up for that. For your baby shower, instead of having family do stuff like just get you diapers and clothes and things like that, maybe ask for some donations to your midwife, your home birth fund, your birth center fund, so that you can take some of that cost off of your direct shoulders and get some of that covered by family and friends. But I think, personally, if that's an option for you, I think it's worth it. Not only because the midwives' model of care is more careful and intentional, and there's a lot less rates of mortality in those spaces. I'll speak to the certified practicing midwife. Especially again with the doula piece too. So not only that, but also it's nice to be able to sit for the home. I'm speaking to home birth here. Birth center birth, you still gotta do the drive. You're still gonna have a limitation of how long you can stay there. But with the home birth option, if that's an option for you with a safe practitioner, that's nice. You literally give birth in your home. You welcome your baby in your own home, your own four walls, and you go and you rest in your bed with your baby. And you stay at home. Now that can be great for some people, but it can be not so great for other people. So definitely take those things into consideration. I'll do another video on that later. If you really want to hear more about my home birth experience, I can definitely speak to that more and talk about the pros and the cons. But just investigate midwife options. Again, there are lay midwives, certified practicing midwives, nurse midwives. My experience were with nurse midwives and certified practicing midwives, and I love them, and I felt very safe because of the certifications they had to go through, and the knowledge that they had. Yes, I felt very good about that. The doula end, look for birth and postpartum care doulas. Those will be people that, even if you go into the hospital, or if you work with a midwife, and you stay with the midwife, or if you work with a midwife and then you have an emergency, you have to go to the hospital, those will be people that help advocate on your behalf. I wonder how different Carrie Jones and Mercedes Wells' experiences might have been had they had doulas with them. That could have spoken more directly to, hey, no, like, they're in active labor. We're not going to send them away. Or we're not going to have them sitting this way. We need to be seen by a doctor right now. And I can't help but wonder about how that experience might have been different with a doula for both of those women. In terms of the clinical space, arm yourself with the knowledge of your rights. I want you to go look at the rights and protections that you have legally. Educate yourself on that information. I think everybody should work to have a doula. So my first time around, I did not have a doula, and I regretted it because then, and they told me to get a doula, but I didn't understand. It was not explained to me well enough to why I needed one when I had my partner there to help support, and they were teaching my partner the techniques of counter pressure and things like that. Like, I was like, what do I need a doula for? When we actually got to the birth, I understood we needed a doula because we were tired, and that would have been another pair of hands to help with counter pressure and to help keep us motivated, to help make sure I was eating because I didn't eat. Yeah. The second time around, I had a doula, and I was actually covered because Dove had a fund to cover people's doula care. I'm going to paste a link to that below. But yeah, I won that, and I got that funding to actually pay for my doula services, which was a wonderful blessing. So there's things like that. I want you to look around and see if there's a way to cut that cost for yourself. But yeah, I think the three main things everybody can do: arm yourself with knowledge of your rights, and what you're stepping into in the clinical space, if that's what you're doing, or into the midwifery space too, if that's what you're stepping into. I want you to arm yourself with a doula, birth doula, postpartum doula. And I want you to arm yourself with knowing your options about the midwife. Not necessarily going to see one if that's not something you're comfortable with. Some people just are not comfortable with that idea. They want to go see the doctor. If anything goes wrong, they want to have the security of knowing that the hospital's got it. It's right there. You're taken care of. You're right there. You're in the hospital. You're not going anywhere. So that's totally fine. But I think it's still important to know about your options and to interview people. Interview those options. Get to know those people. Come up with some questions to ask people to get a better understanding of how they function, what they do. Ask your OBGYN. One of the questions I was asking is like, what do you do when there's emergencies? What are the signs of someone being in trouble with their birth or after their birth, and the things to look out for? How do you know that someone is in trouble? And sorry, I started crinkling tape. What are the things to look out for to know if I'm at risk? How much blood do I need to be scared about if I see spotting or whatever? What other symptoms do I need to know about if there's trouble, so I can say something? Who do I talk to if I'm not being listened to? If I'm giving delivery here and I'm having a negative experience with the person that's supposed to be taking care of me, whether that be a nurse or an intake person or whatever, who do I talk to? Who do I get to get to you? Who do I get to get to someone I trust? How do I make sure that I'm listened to? After I give birth, because this is a lot of the space where people start passing away from maternal mortality rates, is like after birth, because the maternal mortality rates are up to a year after you give birth. What are the things that I need to know personally and I can check for after I give birth to make sure that I'm good, or that I should pay attention to? And if someone's not listening to me, who do I talk to? What's the chain of command here? What do I do so that I can make sure I'm alive and I'm here for my family? Ask those questions. Get answers to those questions. Know the answers to those questions and go forth. With that, I'm gonna just go ahead and draw attention to preeclampsia and eclampsia, because it's one of those things that we can prevent the maternal mortality around. And this is something that has to do with like checking your blood pressure. I recommend every pregnant person, every birthing person have a blood pressure cuff. One thing I learned is that my library system actually gives free blood pressure cuffs. You can rent them from the library. You might have a local organization that can rent them out. You might have it available with your insurance. You might have it available at your clinic. I want you to ask around and figure out how you can get a blood pressure cuff. And I want you to note the blood pressure rates that are dangerous or are like, ooh, we need to keep an eye on that. I want you to have that information. And I want you to check your blood pressure through your pregnancy, especially if you're starting to have a headache that won't go away. I want you to keep an eye on your blood pressure. I want you to do that during your pregnancy, and I want you to do it after your pregnancy. For how long? I don't remember. Ask your medical professional. That's the last little thing I want to say, arm yourself with, actually. It's my little bonus point. Arm yourself with a blood pressure cuff. Okay. That's everything I want to talk about. I've gone on and on, but hopefully me pointing out the things that I pointed out here today are helpful and will help save some lives, because this is ridiculous. We cannot continue to go on this way. And that's just that on that. I'll see y'all in the next video.